Welcome to our NCD online course to the topic of cardiovascular disease prevention, and I'm giving here an introduction to it. The epidemiology component of cardiovascular disease. And here I use and recommend you and put into your reading the Global Atlas on Cardiovascular Disease Prevention and Control, which was issued by my former colleague Shanti Mendes 2 years ago at WHO Geneva headquarters. It is freely available and you find the link in your material, and you see a lot of very interesting and scary to some extent statistics. I show you only this one here. Look at the world map, different colors from green into over yellow, orange to red, representing the distribution of cardiovascular disease mortality rates in men. Age standardized per 100,000, so you can actually compare the different countries amongst each other. Now, where do you want to live? Are you surprised that the green areas are those ones with the lowest cardiovascular disease mortality rate, and the red areas with the highest rates we actually find in areas where we thought those ones, or conventional wisdom, kitchen sink epidemiology told us that the African continent is the continent of infectious diseases and not NCDs. Look at this picture, it is actually the opposite. The lower cardiovascular disease mortality rates are here in the old world, and the higher rates in these countries. Why the difference between countries, between regions? Now, Salim Yusuf in his 2001 paper picked up this old notion of the epidemiological transition and translated or applied it to cardiovascular diseases. And I think this is a very nice slide, even if I normally am not the greatest friend of this transition model, because in many countries, especially in Africa, it doesn't quite apply. Now, have a look here, the stages of transition, I would say, rather than development. You have the age of pestilence and famine, receding pandemics, moving into the age of degenerative and man-made diseases. Those are the classic stages in the original 1971 Omran paper, where in relationship to cardiovascular disease, the percentage of total death is obviously very low here, and peaking in the age of degenerative and man-made diseases. Strokes of all types, ischemic heart disease at young ages, obesity and diabetes being the key drivers. And he says, if you look at the world's region, currently urban India, former socialist economies, aboriginal populations are stuck in this age. But he projects it even further into an age of delayed degenerative diseases, and that's where Western Europe, Northern America, Australia, New Zealand is. As you saw at the map before, we have actually lower rates of cardiovascular disease than these other countries. And then he's adding a fifth and last stage of health regression and social upheaval, and as an example, his work in Russia he is quoting there, where you can find a re-emergence of rheumatic heart disease, infections, ischemic heart disease, hypertension disease in the young related to alcohol consumption and other re-emerging risk factors. So that's an interesting, rather more wave-form development. And there is also in this paper a graph associated with, and his emphasis is that currently the cardiovascular disease rates between India and China and North America might be quite similar, but if you look at the development, those two countries are on very different phases of their development. And his His argument is that this curve should be seen in all countries, but is occurring in countries like India and China at a much, much later stage. So therefore, his predictions are that those two countries have not nearly peaked at their main rates of cardiovascular disease. It's an epidemic here yet to come, whereas in Northern America and Western Europe, we see since the 1970s a clear and ongoing reduction, actually also in Australia. Now, we had already in our first session on demography learned about the influence in the change in population and disease patterns. Any decrease in childhood and infectious diseases will in turn result in a larger age, middle age and older population group, and that by default is more prone to have age-related diseases such as all NCDs, CVD included. Globally, we unfortunately still see an increased tobacco use, and again the decrease is mostly observed in the countries we mentioned before: North America, Europe, not all, rather the former Western Europe and Australia, but steep increases in China and India. Then a global shift in the way the places we are living move towards urbanization, and that results in reduced physical activity, increased energy consumption, access to high energy dense fast foods, also goes along with increased fat consumption, and then an increased level of psychosocial stress. This in turn results also in increases in weight and obesity, with the resulting dyslipidemia, meaning more bad cholesterol, less good cholesterol in your blood; dysglycemia, meaning higher levels of glucose in your blood; and increased levels of blood pressure, the key driver for cardiovascular disease. So those are rather universal patterns we see at different stages in different corners in the world. And we have later in the course a whole segment on the urbanization and what that means, because if you just look at this slide in an overview, you realize that even in developing countries, the lowest line, there is since the last 30 years a doubling of the rates of people living in more urban centers. And actually, I think we passed the point last year or earlier this year where the majority of people, just over 50% in the world, is now living in urban settings. So Salman Yusuf, in this paper I mentioned, puts it all together as societal pathophysiological pathway for coronary heart disease, where you see this shift from, on the left side, shift from the rural lifestyle to urban lifestyle, with all those associated determinants of behavior, leading positively, leading to more stress, more sedentary lifestyle, more consumption in energy-rich foods, leading to obesity and other risk factors. We mentioned salt and hypertension, and then we have some modifying influences on a population level: access to healthcare, preventive services, genes and knowledge and attitude, but also access to, let's say, fresh fruits and all the other things we saw in those pictures before. And that then explains the different rates of clinical events and cardiovascular disease mortality seen in the different countries. And having already talked about obesity, I just wanted to flick in this one slide. The cutoffs for overweight being globally defined as with a BMI of greater than 25, and obesity as greater than 30. Here you could ask yourself, where is this normal standard derived from? And at this very much from modern day Western countries, and that might not be appropriate to other countries. And if you look at those historical examples, the median BMI of 16 years old in the US even is 16. 20 of 20-year-olds, but around 1900 the median BMI in the US was 21. Currently in India, in a study in rural Bangalore, is 19.5. In the Anqing study in China, it's 19. So how comes we consider 25 being the cutoff for normal? To summarize, when you want to examine cardiovascular disease differences between regions or your countries, then you do have to take into account the state of development of the country in relation to this epidemiological transition. And if you use the transition, go all the way and use the 5 stages as indicated before. The level of urbanization with the different components impacting nutrition and physical activity and psychosocial stress. Then variations in ethnicity, cultural and biological ones, and last but not least, differences in socioeconomic status leading to different lifestyles. Overall, one can conclude there are a couple of fundamental tenets about CVDs, and I like to extend them to all NCDs you should have in mind. The first one is that obesity, cardiovascular disease, diabetes can be seen as normal biological responses to an abnormal environment. The next tenet is that biological factors are generally deterministic, hence the intervention strategies are more generalizable. The example for CVDs is blood pressure as determining factor of cardiovascular disease. Intervention strategies to reduce blood pressures are very generalizable across the world. Now, societal factors, and there are many determining cardiovascular disease, but also other NCDs, have a much more contextual impact. And therefore, approaches to interventions, community-based or societal interventions, need to be much more variable than interventions on biological factors. Keep this in mind when we move on to look at the different examples of interventions. And this is the third part and last part, where I want to introduce you to 3 examples of preventive interventions to reduce the cardiovascular disease burden. Let me introduce to you briefly those 3 examples. You will find the links also on our website, so you can just click and it should open in your browser. First, the Million Heart Initiative, led by the CDC. An initiative to prevent 1 million heart attacks and strokes by 2017. And if you look what activities they are planning, then you realize the ABCs: aspirin for high-risk patients, blood pressure control, cholesterol management, and smoking cessation. That is a typical clinical high-risk patient approach. Later down in the text it also says we encourage community-based efforts, but they are far less specific than here with those slogans. You can on this website watch the initial presentation on YouTube, and I would recommend you to watch actually not the full hour but only the 10 minutes starting from minute 25 and 27 seconds to minute 34, because there you are being introduced to what's happening in New York, the New York Chronic Disease Prevention Program, the Department of Health of the New York State, which in my eyes has one of the most comprehensive and advanced cardiovascular disease prevention projects you can find. So please look up their websites or watch the YouTube video and see how many resources they have and what they actually have achieved already over the last 30 years. The next and last source of an intervention example to reduce NCDs. The next example to reduce cardiovascular disease is what is offered currently by the EDC, is a so-called sodium reduction toolkit. This turns out to be a huge resource, 7 self-guided modules, each of them about half an hour long, on learning about the risk sodium is posing to cardiovascular disease and what measures we have to reduce it. And you can either watch the presentations, and I recommend to watch the introduction, it's only 8 minutes, and then to concentrate on the first module, the global impact of sodium of health, where you learn that, as I said before, about 75% of sodium consumed in the US, and that's not much different than in other developed countries, is actually coming from processed and restaurant food and not added by the person at the table. So therefore it's not surprising that people are largely unaware of how much sodium they consume every day, and you can already guess what kind of interventions this toolkit is recommending. Interventions at the level of policy and environmental interventions. If this presentation doesn't load quick enough, or if you have difficulties, you can actually also from the website download the PDFs, where you not only get the presentation but also the notes, and at the end also the references used in this document, or in this toolkit, as they say. So go to that website and check out the sodium reduction toolkits and focus on the second presentation, global impact on sodium on health. If you have more time, you're of course free to watch the whole thing. And with that, we are at the end of our topic, Introduction to Cardiovascular Disease Prevention, of our NCD online course.